So now moving towards our next session, would like to call chairperson Dr. J.K. Saini sir. Dr. J.K. Saini sir as a chairperson. Dr. J.K. Mishra sir, IMS BHU. And Dr. Recha also as a chairperson. The next topic is the next step in COPD care by Dr. Sushmita Chowdhury ma'am. And for unka hai.
Good evening. Thank you for being still here. A long day of talks. Yeah.
Next talk is by Dr. Sushmita Roy Chowdhury madam, and she graduated from Calcutta National Medical College, then MD from KGMC, and she worked at Institute of Pulmocare and Research, Kolkata, and trained in UK, and European Diploma in Adult Respiratory Medicine, and so many things. And now I invite Madam for the talk.
Thank you. Thank you, Dr. Pathak, for inviting me again. It's always a pleasure. And also, definitely, Professor Rajendra Prasad, our teacher, is also here. So, without further ado, can we show the slides? So, basically, is COPD, what is COPD? We all know that it is not homogeneous, it is quite heterogeneous, and it's a lung condition characterized by respiratory symptoms. The patient comes and tells you, I have dyspnea, I have cough, I have sputum production. Not always, it's the chronic bronchitis type that have it, but in emphysema, they might present just with infection. And it is progressive, that is the main point. It doesn't stop, it gradually progresses. And our job is to try and stop the progression. And that is why I have a lot of slides here where I'll be talking about just the basics that you need to take away. These are busy slides, but just what you need to take away. What is most important, and we have to realize, is as an asthma, we try and treat inflammation by treating with inhaled corticosteroids. But long term, we have been told in COPD, you treat symptoms. And that is why you have to use bronchodilators. Is it the same or has that changed? And that is what we are going to look at. What we know very well now is that the burden of COPD is substantial because they have to spend a lot of money on their medications, in hospitalizations if it is not well controlled, and just one moderate to severe exacerbation can lead to decline in lung function progressively, and these exacerbations can cause mortality. And therefore, low expectations are there with treatment. Even with the doctors, oh COPD है, सांस की दिक्कत नहीं हो रही है, ज़्यादा हो रही है, inhaler दिया है, लो एक और inhaler ले लो. But is that enough? We have to try and look at ourselves whether we can have a more clearly defined endpoint to align management and give them a good quality of life. After one exacerbation, when we discharge patients, they tell us, हम ठीक नहीं हो रहे हैं. How long does it take? You have to give them clear indications. Here is evidence which shows that even with one moderate exacerbation, it takes 6 days before a patient starts feeling better when you have treated them with steroids and antibiotics. In hospitalization, it takes 35 days before the patient starts feeling to their admission levels. So you have to realize that that is an expectation you have to fulfill. What can you do to make that bring it down? Because severity and frequency of exacerbations are associated with the risk of death. As you see, that red line there, that is one severe exacerbation increases the number of death in a year by significantly, and this has been incorporated in the American Thoracic Society guidelines. And therefore, the COPD optimal management pathway is extremely important. We now know that COPD is not just one disease, it comes with phenotypes. What does that mean? Lots of our patients have asthma since childhood and have then smoked or have been exposed to lots of pollution, and they develop COPD. So that is an asthma phenotype. There are patients who have had TB and now develop COPD. So that's the TB phenotype. Patients who have bronchiectasis and now have COPD, that's the bronchiectasis phenotype. So the bronchiectasis phenotype patient will make a lot of sputum. So you have to treat that secretions also along with treating the airway dysfunction. So optimum management of COPD has to be done after phenotyping, and follow up the patients, as Dr. Khildani was saying, every 3 months to 6 months to make sure that they are stable enough. So goals for stable COPD are relieve their symptoms and reduce their risk of exacerbations, and only then your patient and you will be happy treating, because these are chronic patients. They will not go away anywhere. They will keep coming back to you if you are assessing all these things together. So each exacerbation, as I said, increases the rate of further exacerbations, and one moderate exacerbation can increase risk of hospitalization by 27%. Therefore, a history of COPD exacerbations is a strong predictor of further exacerbations, and what they showed was if they also have increased eosinophil levels, in adding inhaled corticosteroids helps, because the lack of prompt escalation in management can result in preventable exacerbations and disease progression. This is a very important slide. What did we do? We used to give these patients LABA and inhaled corticosteroid. So what they have shown that even those patients who were on LABA and inhaled corticosteroids had a more than 40% risk of exacerbation and more than 40% risk of still being symptomatic. So by just giving LABA and ICS, you are not only not treating their symptoms, you are also increasing their risk of exacerbations. Therefore, LABA and ICS is definitely not the best combination to be had. And if you delay the treatment by adding a triple therapy, which is inhaled LABA, LAMA, ICS combination, you can increase the risk of exacerbations in these patients. So it is no longer, this slide is important, that in 2024 guidelines, GOLD does not recommend ICS LABA. Instead, they tell you that you have to take it from the LABA-LAMA ICS combination. I'll show you in a minute. And when we are stepping up from ICS LABA to LABA-LAMA ICS, you must choose that the molecule is good, the clinical efficacy and safety trials are in place, and that the device, which is the most important part, aapne likh di dawa, patient is unable to take the medication, patient, you cannot take it. Now they say from multiple inhalers come to single inhaler therapy. The reason being, agar mujhe roz koi dawa lene bole, and if they say आप 2 बार लीजिए और एक कोई डॉक्टर बोले 1 बार लीजिए, I will probably be more compliant if I have to take it once rather than twice. And therefore, single inhaler, triple combinations are the way forward, and therefore, a combination approach is absolutely important in optimal management of these COPD patients. And so, what has GOLD done? It has helped us. Previously, we had this A, B, C, D. As you see here, in 2022, this was very complicated. Now, knowing that your patient is in either A, which is low symptoms, low risk, B is high symptoms, low risk, and E is the category that you have to look for, where when do you call somebody an exacerbator phenotype? When they have more than 2 moderate exacerbation or more than 1 leading to hospitalization. And you must look at these patients very, very carefully. And as you see, from 2022 to 2024, the change is that directly from LABA-LAMA, rather than add ICS and LABA, they say you go directly to triple therapy to reduce the risk of exacerbation and worsening of these patients. So this is how it should be done. And now, what are the medications that we have? Let us talk about the benefit of single inhaler drug therapy that we have in hand. And this is the latest that we have in our armamentarium, which is fluticasone furoate, umeclidinium, and vilanterol, together in one inhaler. So what is the evidence that we have for that? It has shown very nicely by the FULFILL clinical trial that exacerbation risk by using it once a day, 1 puff once a day, reduced exacerbation risk by 44%. The lung function improved by 171 mils after 56 weeks of therapy, and symptom controls was 59% greater. And I can tell you by personal experience that having shifted, I used to always think, how are these patients who are so symptomatic, give them 1 inhaler, 1 puff once a day, how are they going to get better? But they actually feel better because these are ultra long acting bronchodilators, and they do really help. and they improve the real world patient outcomes, as this was seen in a retrospective analysis in an American study. And what they showed was that the reduction rate was by 25%. So that is a huge number when it comes to COPD patients, because each of these exacerbations puts them down significantly monetarily. And a network meta-analysis has shown that compared to budesonide, glycopyrronium and formoterol, this combination demonstrates a significantly greater improved at 24 weeks when it is done. Therefore, there's enough evidence now to suggest that this should be used. So can we be more ambitious about our patients now? Why not? It's a chronic disease. Because we are looking at disease stability, the lesser the number of patients comes to you, when we look at things like lupus, psoriasis, or multiple sclerosis, we are looking at disease stability and not disease cure. So therefore, we should definitely be prioritizing our patients. So what are our goal endpoints? Minimized exacerbations, stabilized symptom burden, and stabilized lung function. Because as we all know that there is a spiral every time there is an exacerbation, and there is, with extended periods of stability and improved lung function, these patients actually feel better. Please remember, alongside this, please encourage your patients to go for pulmonary rehabilitation. Most pulmonologists do not insist enough on pulmonary rehabilitation, and that is one evidence, that is one step apart from proper pharmacotherapy, which will help your patients significantly. So always add these patients to stabilize their symptom burden. Okay, so what does data show for symptom burdening? As I have already spoken to you about, Fulfill trial post hoc analysis, which was a phase 3 double-blind randomized controlled trial, has shown that after exploratory definition at 56 weeks, exacerbations, I will show you here, with the SGRQ, which is the symptomatic way, it shows 50% improvement. And in CAT containing device, which is your, again, symptom-based device, it showed a 49% improvement in these patients. So these patients were stable for 5 times longer compared to budesonide formoterol group alone, which is LABA-ICS group again, as we were talking about. And also, the disease stability for my patients would be twice the improvement in disease stability and 5 times in their symptom management. And that is great for me. So burden of COPD on patients is substantial, yet our expectations of these lives are often low. And I think from the talk today, if you take one thing back, please try and change over to inhalers that your patient will use and use effectively. So SITs are very, very important. Here you get 24-hour anti-inflammatory action with fluticasone furoate. Imiclidinium will give you a 24-hour bronchodilation, and vilanterol will again give you a 24-hour bronchodilation. Therefore, once a day will improve compliance and also help your patients with easy-to-use device, as I said already, like a device that we have here. So if I was to summarize it quickly, we know that COPD is a major growing healthcare burden, and we have in our country so many reasons that cause it. Therefore, there's a need for early optimized management to prevent exacerbations and premature death. Just one exacerbation requiring oral corticosteroids has increased the risk of COPD hospitalization and death, and the impact goes beyond the lungs. Remember, it also affects your heart with increased risk of cardiovascular complications, and proactive management is extremely important to reduce risk of premature deaths in these patients. Thank you very much for your patient hearing.
We are running short of time, so would like, any question? Mic. Mic. A question from Dr. Swapnil.
These COPD patients, so as per Gold 2025, they say that patient on LABA-LAMA-ICS combination, so the cutoff is absolute eosinophil count, that should be 300. So someone who's less than 100, so we can't use LABA-LAMA-ICS in these patients of COPD, irrespective of the phenotype, whether he's a frequent exacerbated with the emphysema phenotype or aegis or maybe chronic bronchitis phenotype.
Yeah, that's a very good question, because what they were saying before is that eosinophil count less than 300, don't give it to them. But on the other hand, they also say if somebody has had one major exacerbation on the current inhaler therapy, reduce the risk of exacerbation by adding inhaled corticosteroids. On something that is very soft, which will never be written in the books, is in our country, we have a significant proportion of patients who have had chronic asthma and have never got themselves treated. On top of that, they have risk factors of pollution, which we again don't talk about. Some of them will be smokers of some sort or the other. And then those are the category of patients. You need to be an astute clinician to assess who is a chronic asthma patient. And guidelines are always to guide. What you will give will depend on what you assess of the patient. Yes, you should, even if with an exacerbation, you should give it.
Thank you.
Thank you, Dr.